For our first speaker this morning, yesterday was yesterday was very intense, and I think everyone can agree. Hopefully this day is a little more laid back and hopefully not quite as intense. And we have today our first speaker is Heather Ellsworth, and we think that we wish we could incorporate more speakers and more topics, but Heather's representing alternative medicine, or more along the lines of therapies that have been around for centuries that sometimes we forget about that can be very helpful. Heather comes to us, she's an acupuncturist and Chinese medicine practitioner in Missoula. She has a master's degree in acupuncture and oriental medicine from the Oregon College of Oriental Medicine, and is a board-certified diplomat in acupuncture and herbal medicine, Asian massage, and oriental medicine as well. She completed postgraduate training in women's health and fertility with Dr. Hong Jin, MD, but also sees a variety of pain conditions in her private practice, including chronic and acute pain conditions, structural imbalances, sports injuries, headaches, migraines, and autoimmune conditions. She is the owner of Mountain Sage Acupuncture and a partner of the Acupuncture Clinic of Missoula. So I'd like to welcome Heather Ellsworth, please.
All right. Hi, you guys. Like Mark said, I'm Heather Ellsworth. I won't talk about myself too much. He already did all that. But yeah, it's an honor to be here representing some of alternative medicine or CAM therapies. I am just representing acupuncture, but I'm happy to be here. So, Mark, you stole my notes. Naughty.
They got stuck.
Thank you.
I thought you could do it without it.
I'm just going to ad lib. My goal today is to demystify acupuncture and give you an idea of what assessment and treatment of a pain condition looks like when a patient comes to see the acupuncturist. How acupuncture works best as a referral relationship, and what acupuncture research has to say about acupuncture and the treatment of pain. First off, what is acupuncture? Simply said, acupuncture is the insertion of fine, filiform, single-use sterile needles into specific points on the skin to alleviate pain or treat various health conditions. In the West, we think of acupuncturists as only doing acupuncture, but actually we're Chinese medicine therapists, so we use acupuncture along with manual therapies like moxibustion, massage, cupping, gua sha, and Chinese herbal medicine, lifestyle advice, and nutrition. It's a holistic approach that addresses the patient's mind, body, and spirit. I'll explain what all of those things are in a second. It's 8 a.m. Let's get some pictures up here. Wake us up. So there's a needle. It's very tiny. It's about the size of a hair. A lot of patients are very nervous about that aspect of things, but once I show them how flexible it is and how tiny it is, it's not inserted very deeply in most cases, and it's generally not painful, their fears go away. A lot of my patients call them pins because of the needle word association. When you come to the acupuncturist, an actual treatment looks like, first an initial consult. A new patient visit is about 1.5 hours to 2 hours. We get a complete health history, initial intake, differential diagnosis, and treatment. Follow-up visits are about 1 hour. They include check-in, a shorter intake, reassessment of the condition and the protocol, and another treatment. When we're taking that intake, we're doing the same OPQRST that you guys are. Also, we do pulse diagnosis and tongue diagnosis, which I'm not going to go over in the time we have today. But suffice it to be said, we're looking for excess deficiency, yin, yang, cold, heat in the body of the patient. So all shoulder patients that come to us don't receive the same treatment. They're each given a differential diagnosis and treated based on their individual constitution. And I think that's a big beauty of what we do, and it's important to not forget to see each patient as an individual and meet them where they're at. So pulse and tongue is a little bit of that differential diagnosis. Also, we're palpating the site of injury or the condition if it's relevant. We're addressing both the channels in Chinese medicine that we're working with, as well as the muscle groups. Observation of gait in the patient and their alignment. So, acupuncture. Like I said, it's the insertion of fine filiform needles into specific acupuncture points. Sometimes we're working on what we call sure points, which is sure, it hurts there. You palpate and there's a tender spot. It's usually a trigger point or a motor point, that kind of thing. When we're doing pain, that's often part of what the treatment includes. Later on, we're going to get into the research side of things, and a lot of our research uses electroacupuncture, which is these tiny little jumper cables that are about like a centimeter long, and we hook them to this handle, that spring part of the needle, and it sends an electrical impulse to the needle that makes it jump a little bit. It's sort of like me standing there and doing this to the needle for a little extra stimulation beyond manual acupuncture. So they use that in research because we can control the frequency that every patient is receiving so that we know that it's streamlined and not varying between each patient. So we'll be talking about that a little later. I just wanted to introduce that. Electroacupuncture is not as common as just manual acupuncture in clinical practice, though. Some other tools that we use, just to breeze over them, but gua sha is scraping massage. That's the translation. My husband was like, why are you calling it scraping massage? That sounds horrible, but it actually literally translates to scraping massage. It's a smooth edge tool, like I use a jade stone, and you gently scrape muscles to create a sha response, that redness that you see in the picture. It increases blood flow to an area and creates a healing response. It's great for acute neck pain. You wake up and your neck is totally stiff and you can't move. You gua sha it and you get great range of motion. Cupping. We use glass or silicone cups to suction to the skin, which gently pulls the fascia and superficial muscle layers up into the cup. Once it's suctioned like that, we can move it around the back, which feels amazing. It's like the opposite of a deep tissue massage. Or you can leave it in place and let the fascia kind of unwind on its own. Chinese herbal medicine is there's a lot of research on this. We're just not going to get into it today, focusing on the acupuncture. But sometimes we're using herbal therapies with pain conditions as well. Again, it's not a herb to symptom. It's a constitutional formula based on the patient's constitution and their presentation of pain. We use teas, granules, pill form, depending on what we think the patient will be more compliant with, really. Massage therapy, when we're in acupuncture school, you can choose different tracks. A lot of us train in Tui Na or Shiatsu as well. Some of us don't. So some acupuncturists will combine massage with their acupuncture. I personally will do sometimes like 15 minutes of massage after acupuncture, and it kind of helps integrate what you just did with the needles into the patient's body a little bit. Acupressure is stimulating those same points with thumbs or fingers. Pain-wise, if patients are super nervous about the needles or with children, oftentimes I'm just doing acupressure, thumb pressure on the same points that I would use with needles. Also, just clinically, when I'm doing labor support for pain, acupressure I've found more helpful than acupuncture because the woman can labor as she needs to, move about the room, crawl on all fours, and I can crawl with her and do the points and move when she needs to move. And you can change the pressure as contractions happen. So that's very helpful. I did a training last year for the L&D nurses at both hospitals and showed them some of these tools, and I've gotten some good feedback on the nurses getting to use acupressure on their patients, which is, I think, an amazing integration because they're with the patients for most of the labor, so it's a great tool for them to have. Moxibustion is a therapy that we do. It uses the Chinese mugwort Aiye plant. We dry it, sort of like rubbed sage. It's dried and rubbed into a sort of foamy consistency that we can roll into rice grain size pieces of moxa that we either burn on the acupuncture points to stimulate the point with heat instead of a needle, Or like you see in the picture, there's these cigar kind of things that's just smells like sage, smells like a big hippie festival. And you burn it over the patient's back to bring heat to that area. So conditions that are hot and inflamed obviously won't receive moxibustion. But for things like really old tendinitis that's just got poor blood flow and it's creaky in the joints and stuff, moxa can be amazing because it warms it up, it brings circulation to the area, it stimulates a white blood cell response. So we're stimulating an immune response in the connective tissue, which is a pretty good adjunct to what acupuncture does. So in order to use any modality in a referral relationship, you as practitioners want to make sure that it's safe, it's effective, and it's going to be cost-effective for your patients. So first off, education. Licensed acupuncturists, they either have a master's degree or now we've got a doctorate degree too in a nationally accredited school. Training is between 3, if you do an accelerated master's, you do 3 years. Mostly it's 4. And then if you add a doctorate onto that, it's 2 to 3 more years. So 6 years total if you do the whole spiel. Hours of clinical experience during school is at least 660 hours, usually more. We do a lot of satellite clinics too, treating pain, detox, that kind of things during school. We do have a board exam. Our National Certification Commission for Acupuncture and Oriental Medicine controls education nationally, and you have to pass all your boards. And you have to be certified in clean needle technique. So state licensing, to maintain licensing, all licensees must complete continuing education credits every year and remain in good standing with the Montana Board of Medical Examiners. Safety and side effects. This is a really nice part of acupuncture because it's generally very safe. When done by an experienced, well-trained practitioner using sterile needles, improperly performed acupuncture can cause serious side effects. That's a National Institute of Health quote. But the most common side effects we see in the clinic are bruising or soreness at the needle site, fainting, dizziness, especially if patients haven't eaten or if they're nervous about the needles, and exacerbation of existing pain symptoms. Cost effectiveness. So this varies a lot. I haven't found a real average of cost in Montana because just no one's publishing that data, but this is what I looked at just kind of doing a market analysis. Average number of treatments varies greatly depending on the patient and the severity and duration of the condition. So when people are like, oh, I tried acupuncture, it didn't work for me, ask a little further because generally patients will try it once, and if it's not this miracle cure, they'll give up. In China, we actually would see an acute pain condition once a day for 10 days and then take a break and reassess. So there, it's socialized medicine. The patients aren't paying out of pocket. They'll come into the hospital and get acupuncture every day. It's totally fine. Here, we have to moderate expense versus treatment protocol. So what we generally do here to make it affordable and effective for our patients is see people 2 to 3 times a week at first for 1 to 2 weeks, then weekly, then every 2 weeks, and then graduate them into some kind of maintenance schedule. That, of course, is being reassessed every treatment. So what kind of pain relief did you get? How long did it last? What severity did it go down? What region is it in now? How's it changing? We're always reassessing that so that we can graduate people sooner while making it effective. So we want it effective without breaking the bank. But if you look at the stats, it's not really that expensive in the overall picture. So every treatment's a cumulative effect, so the patient gets the best effect over a shorter course of treatment. Cost of a follow-up assessment and treatment in Montana is between $65 and $95. There are some clinics that offer a sliding scale, like group clinics. I've done a hybrid model in my clinic in the past. I've had to stop recently, but where I do 1 day a week where it's a group clinic where I see multiple patients in recliners at a time so that they can pay a sliding scale, just to make it more affordable for many different kinds of patients. There is a clinic here that does that. I think there's one in Bozeman too, so that's an option for people that really can't afford the 65 kind of deal. A lot of clinics acupuncturists, we just want to help people. So we do offer financial hardship in some cases. It's not something we advertise, but if a patient is really improving and can't afford it, we always have that conversation with them too. But in general, 65 to 95, most research shows a huge shift in pain around the 5th treatment. So trying to get people to at least commit for that first 2.5 weeks of 2 to 3 times a week, we see the best change. How does acupuncture work? This is a very interesting question that there's a lot of research. I was just in the PubMed rabbit hole for a week here, and there's so much cool stuff that we figured out. And then from the Eastern side of things, a lot of us are having some interesting debates about how all this got translated and how it might be better translated to fit what we know about mechanism of action now. But we're going to stick with the research side of things for today for time. In Chinese medicine, we say that pain comes from the stagnation of qi, or vital energy, and we use acupuncture points to move qi smoothly through the 12 main acupuncture channels of the body in order to treat pain. So you can kind of see there, but that's a back view of some of the channels we have in Chinese medicine. So if someone has pain on the bladder channel in the back, we'd be palpating that entire channel and the muscle groups that pass beneath it and assessing that pain. One thing that I think is important to note is there's nothing on the acupuncture needles. We're not dipping them in medicine. We're not adding anything to the patient's system. We're simply stimulating the body's own response to the insertion of an acupuncture needle to promote optimal functioning of that body. So how does that happen? How are we stimulating optimal function of a patient's body? From Western side of things, let's go to the research. So one of the best studied effects of acupuncture is its analgesic mechanism. That's kind of how acupuncture got introduced to the West. A journalist was in China. He received surgery and got acupuncture for anesthesia while he was there. And they were like, what was that? That was amazing. So that's what we started studying first. There's a lot of research. This is just 2 studies. But we do know that when patients receive acupuncture, it helps release the production of endogenous opioids and endorphins. Another interesting side of research is fascial planes. So there's an 80% correlation between the location of acupuncture points and channels, that picture that I showed you here, and the connective tissue planes in the body, the fascial planes. There's Lan Zhivin here. She is pretty devoted to that research, so she's got a ton of studies. She's also looked at what the connective tissues do in those acupuncture locations when you put a needle in and stimulate it, like a small twisting motion. There's an effect she calls needle grasp, and that needle grasp is the fascia looks like little white spider webs. It wraps around the needle and causes alignment of the connective tissues up and downstream from that site. So one of the questions they're looking at is, would this explain how acupuncture's healing effects are delivered to the body? Because oftentimes, we're not only putting a needle where it hurts and affecting that pain. Sometimes we can put a needle in someone's knee to affect their elbow, or distal acupuncture is what that's called. So how is that message even getting there is one of our questions. So there's some really interesting research on that. That is one important thing to note. I had a patient the other day who got surgery, and her surgeon just said, you can get acupuncture, but make sure they're not putting needles at your surgery site. I just wanted to make clear for the MDs in the room, that's not always necessary. We can have this effect that I'm going to talk about by doing points away from the surgery site. We can help that site heal. So there's some interesting stuff on abdominal adhesions post-surgery too, and acupuncture with a point that's on your knee too. So I'm totally happy to geek out with you guys after the talk about that if you're interested. Also, we know that acupuncture causes an increase in anti-inflammatory M2 macrophages, and IL-10, the interleukin-10 concentrations in muscles go up with acupuncture treatment. So we think that's part of how it's reducing pain and inflammation in the pain conditions. So what can we treat with acupuncture? There is a lot of research on this. I tried to include the ones that come up the most for patient pain conditions and for referrals to the clinic. So the first one by Vickers compared sham controls for back and neck pain, osteoarthritis, and chronic headache. It's a meta-analysis, so they looked at all the studies for all of those conditions. And they all had less pain compared to sham controls of acupuncture. So sham controls, the placebo control in Chinese medicine, usually we have these little tubes that we use to insert the acupuncture needles. They'll glue the tube to the patient's skin and then tap it so that they're getting a stimulation and they think they've had acupuncture. So you can't do this to a patient who's actually had acupuncture. And that's the sham control, or they'll put needles in non-acupuncture sites, which is actually a very heated discussion in itself. So if anyone wants to talk placebo after the talk, we can talk about that. But usually the sham control is either that tube tapping or a non-acupuncture site being needled. So neck, back, osteoarthritis, and chronic headache all responded better than the sham control in that meta-analysis. For neck pain, this study by Trin, acupuncture was found to relieve neck pain better than sham acupuncture, and then waitlist or inactive treatment. So they're comparing people that received no treatment and sham and acupuncture. And the acupuncture group did the best. They only did a short-term follow-up. That study didn't look at long-term benefits. Fibromyalgia is something that we do see a lot in the clinic. In general, my fibromyalgia patients like a very gentle needle stimulation, but with that, they can change a lot with very little stimulation. Individualized acupuncture treatment for fibromyalgia was efficacious compared to placebo, and effects persisted at 12 months. I think with this one and with, well, really with any condition, but what really came up with the fibromyalgia, and we're going to look at a TMD study in a second, is we also treat the anxiety and the emotional aspect of why these patients have this pain. So we're not just going to treat the physical, we're going to treat why are you stressed, why are you clenching your jaw, that kind of thing. So acupuncture has a great anxiety releasing effect that we're not talking about in this study, but that just happens. Even if I'm treating pain, people fall asleep, they're relaxed. It's a very relaxing therapy. So treating the spirit and the mind with the body is just, you can't separate them in this medicine. With headache, this study showed the available evidence suggests that a course of acupuncture consisting of at least 6 treatment sessions can be a valuable option for people with frequent tension-type headache. So, and that's again, 6 treatments. So the frequency of the course of treatment is important to the effect too. I know a lot of my friends in Western medicine and referral relationships, they want to reduce the amount of opioids that they're giving their patients and NSAIDs. There is some research looking at that. And I thought this one was really interesting because these women have undergone lower abdominal surgery, and they had patient-controlled analgesia. So they could press a button, thanks, and get some morphine. And when they had acupuncture at stomach 36, it's a point in the knee that's a control point for the abdomen, so it helps with pain there. They showed a decrease in the amount, an increase in the time before requesting the first dose of the patient-controlled analgesia, a decrease in the amount of morphine used in the first 24 hours by 61%. Oh, this is the one that's comparing high-frequency electroacupuncture and low-frequency. So the high-frequency one, they were getting 100 hertz. It's a 9-volt battery. It's a very tiny stimulation, but still the higher end of things. They had a 61% decrease in the morphine they requested, and the low-frequency electroacupuncture group had a 43% decrease. And then they had a control group that didn't get acupuncture, so that's what they're basing the numbers on. In the elder study, this was one of my teachers, actually, Hammerschlag. This study was done with the clinic results from my school, so the TMD, or TMJ, joint dysfunction. So patients received not just acupuncture, but a very holistic, all of the tools that I introduced in the beginning to treat their stress, their sleep, the pain in their jaw, their headaches, and they looked at NSAID use. And the heaviest NSAID users before the study that were using that to manage their pain observed a short-term reduction in NSAID use that was sustained as TCM visits, meaning traditional Chinese medicine, all the tools at our disposal, became less frequent. So acupuncture can be a great part of an integrative approach. It's effective for pain relief, it has a low incidence of side effects, and is safe when performed by a licensed professional. It's a good adjunct for patients that want to avoid or reduce their use of pain medications. In fact, I'll show a link in a second, but there's a NADA protocol, the National Acupuncture Detox Association. And for some patients that want to reduce their meds and are detoxing from that process, we have an ear protocol that we do in certain settings that's really easy to access on patients in like an inpatient setting even, because they don't have to lie down or take their clothes off. And it decreases the symptoms of withdrawal. It calms them down. So there's a lot of integrated care with the NADA protocol and opioid use, but that's another talk. But just so that you guys know about that. We're trained to collaborate with and refer to practitioners like MD, primary care, DOs, PT, for injury and pain conditions that seem out of our scope of practice. We're worried about something beyond just shoulder pain going on, or if it's not responding to treatment the way we usually see it respond to treatment. So we're team players. Here's some other resources. The NADA protocol I mentioned. Our board in Montana, the Montana Association of Acupuncture and Oriental Medicine, has a table outside with some information. I've printed out all the research studies because I just introduced a lot of stuff. So all the research studies are in paper form on that table if you guys want those. Or if you want to email me at my business email here, I'm happy to send them to you that way too. I hope I've helped give an overview of acupuncture's treatment approach to pain and ideas for how we can work together to offer our patients an integrative approach to care. Thank you.
I was wondering, how is your work or your, I guess, treatment plan or whatever affected by someone who's had surgery? Because that can either alter or completely interrupt the channels of energy in the body.
You mean, how would I treat someone post-surgery?
Yeah, I mean, how does it alter what you might do?
Yeah, I mean, in the way of, like I said before, if someone's like really soon post-surgery, I'm not putting needles anywhere near a surgery site. So we're doing more distal needles to increase that anti-inflammatory effect I was talking about and that analgesic effect I was talking about to help the patient heal from the surgery and to help with the pain of the surgery. And then sometimes with like old surgery scars or something like that, we do some scar therapy and stuff, which doesn't mean we're putting a needle in the scar either. But like I was talking about with that abdominal surgery study, there's just one study, so I wasn't going to present it here, but I've just seen in practice a lot of like abdominal adhesions post-surgery and pain or structural imbalances from that. And so because we're looking at how the channels flow through the whole body, and you can think about that as just from a Western term, like structural alignment, whether it's physical or energy, we hate that word, but you've got to look at how is that scar tissue affecting that structural alignment. And so we do various things to clear those channels so that that scar tissue doesn't affect that, if that makes sense. Okay.
You said that most of the insurances will cover
Yeah.
this. Does Medicare and Medicaid for the
Nope.
state of Montana?
Not Medicare, Medicaid. But since the Affordable Care Act, there's 2 more plans. And then recently, there's been a couple, at least in Missoula. I should have brought the list. My front desk has it. But there's at least 10 that I'm credentialed with. And I would say 80% of my patients are insurance patients. So it's getting better. When I was working in Oregon, almost everyone has acupuncture coverage. So just great frequency of treatment, good follow-through with protocols. When I moved here 4 years ago, it wasn't that great. So I wasn't even taking insurance at first. But in the last 2 years, it's gotten a little bit better so that I'm actually deciding to do that again because it's worth our time. So there are quite a few. I didn't see who asked that question, but, oh. Yeah, there are quite a few plans. But unfortunately not Medicaid, Medicare. Yeah. Reiki? I don't use Reiki, but I've worked with people that have. In our clinic, the massage therapist there does Reiki too. Yeah. Uh-huh. Oh.
In your opinion, as we see more and more people receiving tattoos,
Yeah.
how does that affect this person's situation? I mean, the getting of the tattoo and then the history of having gotten the tattoo.
Yeah. That's something we like to theorize a lot about. I haven't seen any clinical changes from a tattoo. Sometimes piercings. There's a lot of idea of you can use auricular acupuncture images the entire body and the ear. And so when you pierce a point, are you constantly stimulating or are you moving it aside? And I think you're not taking tissue out. I think you're just moving it aside. If we're talking about fascial planes and the activity along those, if you're piercing something, the fascia's there, it's just moved. So I think the point is moved. I don't know that I don't know. I don't really think they're affecting anything from what I've seen. Yeah, but it's I'm gonna keep watching for that. Yeah.
People who are taking particularly strong narcotics or medications of different kinds, do you see a different response with acupuncture when they're doing that?
Yeah, sometimes, in private practice, I don't see anyone on a really high dose very often. When I was doing internships at the detox centers in Missoula and stuff, sometimes you'd see patients that were on a pretty high dose. Their pulses are muffled. It's a cotton pulse in Chinese medicine, so there's sort of a masking of what's going on with them a little bit. And sometimes they don't feel the needles. I'd have issues with people moving with them in or rolling over on them or something. That's an extreme case, but that's as extreme as I've seen. But there was still some effect. It's sort of like treating them through a layer of cotton, though. But usually on a normal dose, those are detox patients. On a normal dose, we can treat as we would a normal person. Yeah. And still get that feedback from their system pretty well. Yes.
Heather, I'm a pharmacist. Thank you for your presentation today.
Oh, yeah.
Occasionally I've encountered patients on Chinese herbal medicine, and I haven't been able to determine very well if there's drug interactions that I need to be aware of. Do you have any tips for us on
I know.
resources?
I wish that there's just not enough research. So, we are trained in how not to combine blood thinners, the herbs that we know that are major blood thinners, with what you guys are using. And we have a few that we're like, just don't use those with pharmaceuticals because we have a little bit of research on them. But in general, I'm not comfortable with the amount of research we have on herb-drug interactions yet. And so I tend to, if they're on a lot of medications, I'll send my formula to the doctor and see, should we try this? Are you okay with that? I always want a communication going on just to make sure. And sometimes I tend to just treat with acupuncture if they're on a lot of medications. Just because, I don't know, I like having research behind that kind of thing. Generally, there's a lot of herbs that we do that are safe and pretty benign for that kind of thing, as far as, topical herbs or just tummy settling herbs or stuff like that. But if we're treating pain conditions where we want something that's blood moving in Chinese medicine, I wouldn't use it if they were on some major medications, yeah. I'm just kind of conservative in general, so, yeah.
Hello, I'm also an acupuncturist, and there's a gentleman named John Chen and he's with a company called Evergreen Herbs. They're a family out of Taiwan that have had generation of experience with Chinese medicine and herbal medicine. And he's a leading researcher for us. He's a fully trained pharmacologist, and him and his family have received lots of money to be able to do research. So if you are looking for more education on drug-herb interactions, it's a course I take from him minimum once a year, sometimes twice a year, just because it is it's a huge discussion in the Chinese medical field right now, is how are the herbs interacting with the pharmaceutical medicine? Because we know a lot of the pharmaceutical medicines did come from these herbs originally and were developed from them. So for us to be really well-versed in that is something that we're really trying to do to the best of our ability. So if anybody does have any questions, the Chen family is very accessible, and they're very accessible to us acupuncturists to be able to call and ask questions and submit questions and give handouts. So again, that name is Dr. John Chen, and you can look him up and find out more information about him online. And their company is Evergreen Herbs. So that's a great resource. In taking his courses, he said, if you do know any Western practitioners that have questions, send them my way, and I'm happy to talk with them. So that's a great resource for anybody. The other thing I just wanted to add on to Heather's presentation today, from being here and attending the presentation, is the two big concerns that I've heard in talking with people are the affordability. And I encourage you, because acupuncture has such a low side effect, and we do see such wonderful results, I really encourage you not to assume that the patient can't afford it. I do have a cash practice, and I'm constantly surprised at how patients, when they get results, are willing to invest and figure out how to make it happen. And as Heather explained, there are options that a lot of us do have in our clinic. So I really encourage, even if you feel that hesitancy, that you don't want to refer out because of finances, I encourage you to let the patient make that decision, because a lot of times if it is something that's working for them and something that has such low side effects and they can decrease medication, I think it's really worth a shot to give them that opportunity. And now I just lost that last thought that I had. But both Heather and I will be here for a while, so if you do have any questions, please feel free to ask. We really enjoy collaborating with Western care providers, and I think bridging that gap and truly understanding what all of us are doing can really help bridge that gap with especially pain cure here in Montana and around the world. So any other questions for Heather?
Thanks, Bree. Crickets. No other questions? All right, should we wrap it up? Okay. All right, thanks again for having me, you guys. Like Bree said, we'll be around, so feel free to ask us any questions.
Good morning again. I'm Linda Torma, part of the Planning Committee, and it's my privilege to introduce Lynn Evans, who's going to be talking about risk management and pain management. Sort of an important issue to talk about in our pursuit of balance in terms of practice and risk, and making sure that we're doing the best thing for ourselves as well as for our patients. Lynn joined UMIA in 2015, following 17 years of providing risk management services to hospitals, clinics, physicians, and long-term care facilities throughout the Western United States. Ms. Evans previously worked for 6 years as a risk management consultant for a risk retention group with insured hospitals, clinics, and physicians in Montana, Idaho, Wyoming, and New Mexico, and as manager of risk management for an Oregon hospital system. Her primary clinical background is in emergency services, with other experiences ranging from director of nursing for a critical access hospital to nursing administrator for a large university hospital. Please welcome Lynn Evans.
I think I might have to adjust this down. Can you hear me okay? Okay, does everybody want to get up and stretch a little bit? Are you okay? Are you, get your, great. Take a stretch. Okay, so I have a very unique perspective on drug abuse. Coming from an emergency background, certainly have taken care of people in the emergency department that have overdosed or that were addicted to pain medications, and it always affects the way that I think of things about how we treat our patients and keep them safe while we're trying to also treat their pain. So I do have a unique perspective, and we were actually talking about this a little earlier. From a risk management perspective, you want to just actually tell everybody, just don't prescribe pain medications to people. That's my risk management presentation. Thank you, I'll take questions now. But that's not ethical. It's not the standard of care. That's not what we want to do with people. We want to be sure that they're adequately treated. So let's go on here. Of course, I have no relevant personal financial relationship in this activity. And because I work for an insurance company, I'll also tell you that this is not intended to be legal, medical, nursing, plumbing, electrical contracting advice. So anything that you get from here is strictly risk management related. So today we're going to talk about a little bit about the scope of the prescription drug abuse problem. I know that I'm speaking to the choir, preaching to the choir here. You guys have probably a lot more knowledge about the scope of the problem than I do. But we're going to talk about a little bit. We're going to talk about different kinds of liability exposure for clinicians. We're going to talk about risk interventions and strategies. And then we're going to talk very, very briefly about emerging risks and new areas of concern. So the scope of the problem that we're looking at is 1,000 people treated in the ED every day for misusing opioids, 165,000 deaths over a 5-year period, 19,000 people died of opioid overdoses in 2014. And the thing that I found very interesting was 91% of people who survive an opioid overdose receive more prescriptions for opioids. And then another startling statistic is the number of infants that are born addicted to opioids every year. And when I worked in a hospital system in Oregon, we had numerous babies that were born addicted, and we had a protocol for that where the baby went home with decreasing levels of medication that was given to the baby by the parents. And it's a tragedy, and people don't understand, I think, that is part of the problem as well. There's also lost productivity, there's medical and legal issues. And then in Montana, we have 72 to 82 people that get pain prescriptions per 100, and we're somewhere in the middle of the scale for that. You see the states down in the kind of the Rust Belt and along in the South that have over 100 prescriptions per 100 people. So clearly their problem is greater than ours, but that doesn't mean we don't still have a problem. There were 369 prescription overdose deaths between 2011 and 2013 in Montana. And the drugs most commonly found in those drug-related deaths, hydrocodone, oxycodone, methadone, and fentanyl. And we're going to see some changes as we move along, trying to affect change. We'll talk about that with the emerging risks. So how did we get here? I think we can look back. I can remember when it wasn't this big of a problem. There's been a lot of pressure on physicians to treat pain. In fact, there's been pressure on nurses to treat pain as well. Everybody has been under a lot of pressure to be sure to treat pain. Pain came out as the 5th vital sign. Everybody remembers the Joint Commission campaign, treating pain is the 5th vital sign. The unfortunate thing about that was we had a 100% increase in adverse drug-related events for opioids after that campaign started. CMS regulations on recognition and management of pain. Now we have patient satisfaction surveys in the hospital saying, rate your pain. Was your pain always controlled when you were in the hospital? That puts a lot of pressure on hospital systems, nurses, and physicians to be sure that the patient is medicated. And is that appropriate? Maybe sometimes yes and sometimes no. There's been very aggressive marketing by drug companies. And then there's multiple social factors. If we look at some of the upsweep in the numbers of addicted people and the areas where the addiction is really rampant, they're in very depressed areas of the country where the economy has really gone down the tubes. And so people are turning to pain medications to relieve their social problems. So 2016 seems to me to be the tipping point. We are now seeing a lot of attention being paid to this subject. I mean, it's like every day that you go on to look at the news, there's something else new out there. And we've had a lot of really high-profile cases. If you remember that Prince died of now what's considered to be an opioid overdose. And you see some of the news issues. I don't know if you read recently that the director of the Board of Nursing in Wyoming was recently arrested for providing medications to someone in the health department, in the Wyoming Health Department. So this is such a rampant problem. It's so widespread. When it's reaching those kinds of levels, we know that we just have a terrible problem. CDC and CMS came out this year and released guidelines for pain management, which is great. There's been a lot of DEA and FDA initiatives trying to keep people more safe, drug take-back programs and that kind of thing. And again, attention from the media, sensational high-profile cases. You also remember that there was a physician that was actually convicted of murder for her prescribing practices. And we'll talk a little bit more about that. There was also the Stanford study that came out this year where it kind of pointed a big finger at family practice and internal medicine physicians that they said are writing most of the opioid prescriptions. And that was kind of a surprise. I think most people thought it was coming from specialties or from just pain management clinics or that kind of thing. But the majority of people that are writing these prescriptions are family practice and internal medicine. And if you think about that, it makes actually perfect sense, because where do people go to initially seek treatment for their pain? They go to their family doctor, right? They say, I have chronic pain, I need you to help me. So it makes perfect sense that that's where these prescriptions are coming from. But the good news here is we're seeing a sustained downward trend in the number of opioid prescriptions being written. That's been for the past 4 years. It's going downhill. So the fact that groups like yours are paying attention to this is making an impact on that. However, no good deed goes unpunished, right? We're going to also see some other unexpected outcomes from that. We'll talk about that too. So when we talk about today, the liability issues that are associated with pain management, I don't want it to make it seem like you should not be prescribing pain medications. What I'm going to talk about is tools that you can use to be sure that you are doing it safely for your patient and also decreasing your risk at the same time. So we're going to talk about types of liability: civil liability, board discipline, criminal liability, and DEA actions. So let's talk about civil liability first, because that's what most people think about when they think about liability. They think about medical malpractice. And because I work for a medical malpractice insurance company, that's where we have our emphasis and that kind of thing. So is everybody familiar with the standard of care? Every single profession has a standard of care, and the standard of care needs to be adhered to by the people in that profession. So this is physical therapy, this is occupational therapy, physicians, nursing, everybody has it. And it's the level of skill, knowledge, and care that a reasonably prudent professional would exercise in similar circumstances. So it's what your office mate and 10 other people in the office would do under similar circumstances. How is the standard of care determined? Well, there's actually a lot of different places where that comes from. It comes from professional associations. So for pain management, that would be the American Academy of Pain Medicine, the American Society for Pain Management Nursing, places like that that are professional associations that come out with guidelines, and they come out with practice guidelines that tell people this is what we think is the best evidence for standard care. The other places are experts and providers like yourself. You are considered to be an expert if you're practicing in your field, and that can be also an expert opinion in a court where somebody will testify whether they believe that you met the standard of care in a malpractice case. Then it comes from regulatory bodies, federal and state regulatory bodies like CMS and CDC can be that, accrediting bodies like the Joint Commission and DNB. And it also comes from tort and law. So when a court case is decided, it actually sets a standard of care. And some of those that you may be familiar with is Tarasoff versus the Regents of the University of California, which was a duty to warn case, so that it says that if you're a psychologist and you have a patient that is dangerous and is making threats to another person, you have a duty to warn that person. So that set up a standard of care. Helling versus Carey, which was a malpractice case if a physician failed to include a glaucoma pressure test in a routine eye exam. And again, these are cases because someone got sued, so the court says, yeah, you should have done that, it should have been done during the routine eye exam. It then becomes a standard of care. Another one is Ribel versus Hughes, and this was an informed consent case that actually was in Canada. That said you have to give people informed consent. So after that ruling, Harvard studies said that 78% increase in the amount of physician time spent in explaining informed consent to patients. So we see that that actually sets a precedent for that to make sure that people are following this standard of care. So when you talk about the standard of care, you're also talking about the standard of care as far as treating pain. Juries have awarded damages in cases that involved inadequate pain management, but litigation-wise, it's almost always involving overprescribing to a patient who is harmed, who is addicted, or dies of an overdose. And a deviation from the standard of care may result in a malpractice lawsuit or other actions. So we're going to talk about a case study. This is one of our actual closed claims. This was a 29-year-old female patient, a new patient, presenting to a family practice clinic with back pain and requesting a refill of her medications. She stated she had a history of bulging disc. Home meds per patient were fentanyl patch and lorazepam. No records from the previous provider. The physician advised the patient that she would not order lorazepam, but she did order a fentanyl patch for a month, with follow-up in a month where she was supposed to bring her MRI results back or get those from the physician. On her next visit a month later, she did have improved pain, of course. Physician received and reviewed the prior record, noted that lumbar x-rays were normal and there was no MRI report included. Patient said she thought that she had had an MRI and she would try to find it and bring it in. The physician still ordered fentanyl, enough for 2 months, and she added pregabalin 2 with a scheduled follow-up in 2 months. Prior to that visit, unfortunately, the patient expired from an overdose of the fentanyl. So I would like to hear from you where you feel that there were some red flags. Yes. You know, I don't have that much detail, but yeah, that was the cause of death was an overdose of fentanyl. There may have been other medications too. Good point. Plus something else. Yeah, yeah. So red flags? Yes. That's a red flag. Good one. Yes.
Then can you repeat the question?
So, to see if there was anything else. That's a perfect example of a red flag, right? Is failure to screen. Oh, sure, Linda. So she asked, was there urine drug screening done? No, not that we know of. So good one. I'm going to show you some of the red flags here. There were no records from the previous provider exactly showing that she did have some sort of a physical problem that required this pain medication, right? A fentanyl patch was ordered without having that information, without screening for her risks. Again, no MRI was ordered or brought into the office on that second visit. She got enough fentanyl for 2 months. She had a new medication ordered. That's red flag there. You don't know how that's going to interact. And those are some of the things that the physician failed to do was they failed to screen, they failed to make sure that they had the original patient records. So in this case, did the provider meet the standard of care? No, they did not. Fortunately for us, the suit was dismissed by the family who decided to sue the drug manufacturer rather than the physician. So in this case, a 42-year-old female in the emergency department with severe blank pain, history of obstructive sleep apnea and obesity. Her CT showed that she had kidney stones. She was on no home medications. She was admitted to urology. The EDMD wrote orders for 2 milligrams of morphine IV every 2 hours, ketorolac 30 milligrams IV every 4 hours. She was given a little bit of morphine in the ED. Urologist gave a verbal order without seeing the patient for 115 milligrams of morphine sub-Q every 3 hours PRN. 115, the nurse gave 10 milligrams of morphine sub-Q. 301, she gave 15 milligrams of morphine and 10 milligrams of zolpidem. No vital signs or assessment before or after the medications. 6 o'clock, the chart notes were that the patient was asleep and or dead. No vital signs, no O2 sats, nothing was recorded. 7:45, the patient was found pulseless by the oncoming med-surg nurse, unresponsive, 25 minutes of resuscitation. Did manage to bring this patient back, but she was found to have a profound anoxic brain injury, and she was removed from life support and expired. So these are pretty obvious red flags on this one. I hope that you guys can help me. What do you see here? First red flag on this? Okay, I'm going to help you. Sleep apnea and obesity. What's that? That's a comorbidity that affects your the way that you respond to a narcotic, right? Exactly. She had no home meds. What does that mean? She was narcotic naive, wasn't she? Okay, very good. Down here, we see that the urologist who did not see this patient gave a very large range dose for this patient, 1 to 15 milligrams. That's a lot of medication for an opiate naive person. The nurse, instead of starting at the low end of the range with this patient, gave her 10 milligrams of morphine sub-Q, and then 3 hours later gave her another 15 milligrams of morphine, and also 10 milligrams of zolpidem. What's zolpidem? You know what it is? Okay, so it's a sleeping aid, right? And it can have other effects with morphine as well, right? Kind of compounds it. And then the next part was no vital signs or assessment either before or after the medication. That certainly does not meet the standard of nursing care. Chart notes that the patient was asleep. There's no vital signs or O2 sats. You should be assessing your patient after you give them a pain medication. You should certainly be sure that they're still alive. That's kind of a very basic thing. And unfortunately, this person was found to be non-responsive. This one paid out $1,100,000. So now we're going to take a look at claims trends that are related to pain management. We actually, for this program, did a study, a 5-year study, on any claims that we had that were related to pain management. This was for a company that is a child company of Constellation, which owns 4 insurance companies. So we had many claims in our database, and 59% of our claims involving opioids allege improper management of treatment and improper medication management. We had $12 million, a little over $12 million, almost $13 million in total costs over this 5-year period. And the setting of origin was inpatient, 62%. That's not a surprise. You think about it when you think about very severe overdoses. A lot of times they occur in a hospital with a PCA pump, or a case like we had there. I've, in my own experience, seen numerous cases with PCA pumps where the person became obtunded and it wasn't recognized and they expired. Outpatient, 22% for clinics. So those are the physicians that are being sued for improper medication management or improper treatment in those cases. So when you look at the medications that are most likely to be involved, looking at hydromorphone the first, so it's high frequency and high severity because it's also one of the ones that pays out the most. Morphine is 15%, and then other opioids kind of all grouped together, they're 53%, and then methadone is 9%. So our hotspots, what I call hotspots for civil liability, our selection and management of therapy. These are the allegations that people made most frequently during a lawsuit. Patient assessment and monitoring wasn't done. Policies in place were not in place or not followed. Staff training and education wasn't done. There were patient behavior factors, and I know that you talk about that a lot with some of the other speakers. Patient behavior is something that you can't always control, but you can control the access to medications. Clinical environment, which is staffing workload, et cetera. Provider behavior factors, we had some of those, and we'll talk about that a little bit more. Failure to question or follow orders. If a physician gives you an order that is like the other one that we just looked at, it's a huge order, do you question that? You're obligated to. Your nursing practice says that you have to. You can't just say, well, the doctor ordered it and I gave it. That's not a defense. Provider, well, I have provider behavior factors in there twice, so it must be important. Failure or delay in obtaining a consult or referral. So when would that occur? If a patient is addicted and you don't refer them to an addiction specialist, that can certainly put you at risk. So this is another two other close claims review. The first one is an anesthesia close claims review. Anesthesia does a lot of pain management. Pain management in this population was associated with 17% of their overall claims. Death was the most common outcome, and that's what struck me again when I was reading through our claim study is death is the most common outcome. That's why people sue you. You addicted and you killed their family member, and so they sue you. 24% of claims were like allegations of addiction, which then led to a death. 82% of patients in the study did not cooperate in their care. 80% had greater than one factor associated with medication abuse, and 24% had more than 3 factors. So are we doing a good job of screening people for pain management? Probably not, and responding to their increased risk. 2011 claims study involving overdoses on prescription opioids. 80% of deaths, a patient had current or past substance abuse disorder. 40% of the cases, the patient has a mental health disorder. Does that mean you should not be treating those patients with pain medications? No, but it means that you need to have a high index of suspicion, and also that you need to be really watching them and monitoring them very closely. Most common errors identified in that second study were initiating too high of a starting dose. What does the CDC say? Start low and go slow, right? Increasing doses too rapidly, converting to a different opioid without following guidelines. You're not figuring out the equivalent dose of one medication, changing them to something else, and it's killing people. They're not screening or monitoring for comorbidities, failing to keep up with new advances in pain management. And this is a big thing. When I go in and I survey patients or physician offices or hospitals, sometimes they have a policy in there that's still typewritten on hard paper. That's the last time it was reviewed, their pain management policy. Is that acceptable? Absolutely not. That needs to be updated. When there's a big change in pain management, like this year with the CDC coming out with new guidelines, you need to be looking at your policies and changing them and keeping them up to date. Not recognizing high-risk patient behaviors, and that's a big thing. So let's talk about all the ways that you can get yourselves into trouble. Board discipline is one way. The other part of civil liability, they're instigated usually when a consumer complaint is filed, or when the board is notified by someone else. It can be another provider, it can be an agency, the DEA can come down, or CMS will report this information to a state board, and then state board will come after you. If the standard of care wasn't met, if you were inappropriately dispensing, prescribing, or administering medications, if you're not in compliance with state and federal law, if you're not initially assessing people, that's another problem, is there is no background for this, this prescription that you're writing. You're not monitoring the person, you're not educating them, you don't give them informed consent. If you're excessively relying on opiates for chronic pain management and not looking at other kinds of therapies, or you're not using available tools that are out there for patient safety and risk mitigation. So here's two cases. California Board of Pharmacy versus Pacific Pharmacy and Thang Tran. This was a complaint that was actually initiated by a neighbor in the area that was due to all the drug activity. They were selling prescriptions in the parking lot. People were lining up in front of this pharmacy at 6 and 7 o'clock in the morning to be able to be there at 9 o'clock when they opened. They were coming from long, long distances, one from as far as 350 miles away to have a prescription filled. And the pharmacist had never spoken to the physician about the kinds of medications that were being written, did not ask patients about their diagnosis, no other medical information about other medications that they might be taking. And again, ignoring those red flags for traveling long distance, the physician writing cocktail prescriptions of the same medications over and over again. So the board in this case found the pharmacy and the pharmacist failed to exercise their corresponding responsibility to verify prescriptions for a legitimate medical purpose, and they revoked their licenses and fined them $39,000. Oregon Board of Medicine versus Purser, a physician failed to obtain or review medical histories of high-risk patients, ignoring high-risk red flags again, transition methadone patients using high-dose opioids without medical evidence, and they failed to conform to the standard of care, subjecting patients to harm. And this physician actually, with involuntarily, or voluntarily, I guess, if you want to say, withdrew from practice. The Oregon Board of Medicine suspended their license, and there was a $10,000 penalty in that case. Pharmacy and physicians tend to be the ones that have board actions for nursing. Nursing tends to have more drug diversion activity where the nurse will unfortunately take drugs for their own use and then refill syringes or whatever to be able to divert drugs. So let's go on to criminal liability. Criminal liability, we've seen some real high-profile cases over the last few years, even in our own neighborhood. I live down in Florence myself, and we had a physician down there that has been arrested for 2 deaths and 398 felonies is what he's been charged with. In Los Angeles, the physician was convicted of murder, as I talked about before, and we'll talk a little bit more about how do you get to that point where you actually get sent to jail for murdering patients. And then there's been drug sweeps where pharmacists, doctors, and their staff have been arrested and tried for criminal charges. So what's the difference between civil liability and criminal liability? They often intersect. You will see a lawsuit against the person for malpractice, while at the same time they'll have a DEA and a criminal investigation going on. Civil liability protects individuals. Failure to meet the standard of care, as we said, criminal liability brought by the government is violation of the Controlled Substance Act. There's an increased burden of proof, foreseeable harm, and criminal discipline, which means jail time or probation or fines. There, again, can also be administrative or civil action at the same time. So the important things to remember about criminal liability: prescription for controlled substance must be issued for a legitimate medical purpose by a practitioner acting in the usual course of professional practice, and a person knowingly filling such a prescription, which would be a pharmacist, as well as the person issuing it, shall be subject to the penalties provided for violation of law. So as a pharmacist, you are not protected because you're filling a prescription just because you think that it's okay that the physician said you should. So this was our case, was Dr. Tseng, who was convicted of murder for overdose deaths of 3 patients, sentenced to 30 years to life in prison over in California. 9 patients of hers died in 3 years. No records of office visits or of the prescriptions that she wrote. The physician forged the records after the investigation began, so once the DEA came in and started to look at her records, she went back and filled in information, but unfortunately they had already copied the records, so they knew that there was no information there, so she was also in trouble for fraudulent documentation. There was a pattern of these deaths that was reported by the coroner's office and law enforcement, and according to the prosecutor, when they called her, they gave her the message, your patient has died of a drug overdose. She did not change anything. And in fact, in court, she said, I told myself that my patient's conduct was beyond my control. Is that true? Does that make you less liable for something like that? Of course not. So criminal actions actually can influence the standard of care, and I think that this is a really important statement to look at, is something that came out of a case. Is a practitioner is not free deliberately to disregard prevailing standard of treatments. To permit a practitioner to substitute his or her views of what is good medical practice for standards generally recognized and accepted would be to weaken the enforcement of our drug laws in a critical area. This is sort of one of those things that science doesn't care what you believe. You can think whatever you want to think, but if there are standards and guidelines out there, you have to adhere to them. So a prescriber of opioids must adhere to professional standards and not practices that materially differ from those professional standards, no matter how strongly those beliefs are held. And that's something very important to remember, that you really need to look at those evidence-based guidelines. So DEA actions, how do they know, right? How do they know who's doing this? That's what I was sort of thinking, is like, wow, you know, are they clairvoyant? Are they monitoring your phone? No, they're not. initiation of investigations comes, a lot of times it's complaint-driven. A patient will complain, a family member, another physician reports, a pharmacist or another professional, and often it becomes from a disgruntled or frightened employee who is afraid that they're going to get into trouble, and so they will report it. A patient death, the coroner will report, family member again reports the death, and then they're getting data from CMS and I'm going to blank out here now, the drug database. Yes. Mm-hmm. I'm sorry? Yes. So the question is, if the DEA is investigating you, are they required to disclose that? They don't disclose it, but generally an investigation where somebody's been arrested or is being investigated is a matter of public record. So I'm not sure about that. Anyway, we'll come back to that. So DEA actions, U.S. versus Freelander. In this case, a physician prescribed controlled substances not for legitimate medical purposes and not in the course of usual practice, didn't verify patient identity or have a medical complaint for them, did not conduct an adequate medical or mental exam, get a medical history or perform appropriate diagnostic testing, didn't establish a diagnosis or treatment plan, they had inaccurate or incomplete medical records, did not assess a risk of abuse for patients, and they prescribed to patients who were misusing drugs. So they knew that they were addicted or misusing or were selling them, and they still prescribed for them anyway. So this person got 9 years in jail, 36 months of supervised release following that, and $300,000 in restitution. This is U.S. versus East Main Street Pharmacy. Over a 5-month period, they filled almost 7,000 controlled substance prescriptions for cash, dispensed controlled substance cocktails. It sounds like the last pharmacy, right? Early prescriptions, ignored indicators of drug diversion and abuse, and didn't even keep an inventory of their controlled substances. So this person also went to jail. So what are liability red flags? People who don't obey the law. It's like, obey the law. That's a big thing, right? Let's obey the law. That's number one. Who breaches the standard of care? They don't assess and treat the person appropriately. They don't screen for family history. They don't screen for other risk factors. And they base their prescribing decisions on patient expectations or pressure. So that's a real problem. Physicians who don't stay up to date on pain medications, pain management, providers who fail to monitor the patient, fail to document, fail to have an exit strategy, fail to identify and appropriate refer addicted and dependent patients. So if you look at the data, this is how the DEA also knows, aside from the complaint-driven process, is the prescription surveillance system data that they get. If you have a higher than average percentile ranking, higher than average rates of abuse-prone drugs, higher than average daily dosage of opioids prescribed or dispensed, days of overlapping patient prescriptions, median distance in miles from the patient to the prescriber or the pharmacy. So if people are traveling long distances to go to your office because they know they're going to get a prescription for hydrocodone, that is a trigger. Patients with multiple provider and pharmacy episodes for the same medications, percent of patients with multiple prescriptions and payment type of cash, and patients with long-acting and extended release opioids. And Medicare sends that same information on patients to both the DEA and state boards. So that is how they know. So let's talk about risk management. And I know I'm kind of running out of time here, guys. I'm cutting into your question time, unfortunately, but I think that this is the most important stuff, so we're just going to go ahead. You can also find me later if you want to ask any questions if we run out of time. Risk management, you don't have to be a risk manager, but you do need to be sure that you're following the law and that your actions are conforming to the standard of care. So top 10 risk strategies, or as I like to call it, the top 10 ways for you to not end up in front of a jury or in jail. Patient assessment, identification of at-risk patients, setting expectations for patients, patient education, informed consent, treatment agreements, patient monitoring, being able to say no in an appropriate way, documentation, and auditing your practice. Patient assessment, you need to assess every single pain patient just as if they were somebody coming into your office with a terrible respiratory illness or pain in their leg or whatever. You need to be doing an initial comprehensive assessment and examination with an appropriate differential diagnosis and documentation for the reason that you prescribed the medications that you did. If diagnostic testing is needed, you need to do it. You need to be sure that you're trying to identify the patient's source of pain. You need to obtain and review records from all providers involved in the patient's care. Think back to our previous case where they did not have the MRI results for that patient. Evaluate and use a current evidence-based pain management guideline. Whichever one you choose, if you choose CMS, if you choose CDC, have an updated guideline that you are following. Use a standardized risk tool to identify patients at risk of misuse or abuse, and I believe that you're having a talk on that soon about which one you might be the best to use. And then recognize, treat, or refer substance abuse disorders. So who's at risk? I think we probably have a pretty good demographic understanding of who is at risk of a drug abuse or overdose. It's age 25 to 54 years, white or Native American, male, but that gender gap is closing very quickly, unfortunately. They have a prior substance abuse disorder. They're using benzodiazepines at the same time. They have a new prescription or a lot of changes. They're on greater than 50 MMEs per day. Patients are taking ER or LA opioids or methadone users. Those are the ones that are at highest risk, again, for drug abuse or overdose. Patients at greater risk of harm from opioid use is people that have some sort of a genetic or comorbidity that makes them more at risk, and that's patients with apnea, COPD, obesity, those type things, pregnant patients, people with hepatic insufficiency, age greater than 65, substance abuse disorder, and a history of mental illness. So these are all things, again, it doesn't mean that you shouldn't be prescribing to these people, but they may need additional interventions and monitoring. So I have a little sample of a risk stratification tool, but again, I know that you're going to be talking about this in depth here. You need to be using a standard risk stratification tool for your patients, and then assigning a level of care to them based on the risk and intensity of monitoring that they need. So if they're low risk and you can manage them within the scope of your practice, that's fine. If they're high risk, they should probably be referred to a pain management specialist, because they need more monitoring and they need more treatment. You need to be checking the prescription drug monitoring program. We have one in our state. We're lucky enough to have that set up. There's also PMP Interconnect that can give you information from other states. Unfortunately, in greater than 50% of the acute pain visits, the patient has already received an opioid for pain within a month. So they're seeing someone else, and you need to be able to identify that if possible and do due diligence to explore the fact that they could be diverting medications. Is the prescription drug monitoring program effective? Well, yes and no, because it's not mandatory. Only about 50 to 60% of providers are using it. There's time constraints, not everybody's updating it, and not everybody has access. So it's a good tool, but remember, it's not the only tool. It could potentially be established as a standard of care for you to check that before you write a prescription, because the CDC has that in their guideline. So something very important is to set expectations. I think it's important for you to talk to your patients when they come into the office. Sometimes they want an opiate, and they think that that is the only thing that is effective for them. You need to really talk to the patient, ask what their expectations are for pain management. Talk about managing pain, not curing pain or making pain go away. People believe that everybody's pain-free. Well, life is pain, baby, right? We know pain exists. What are the best ways to treat that pain? That's part of it. Patients, again, they may believe that is their only outlet, and you need to be sure that you're offering other therapies to be able to do this. So, patient education, use a patient tool that is up to date, and be sure that you are reviewing that with the patient. That's part of the informed consent process, that they know how to take the medication, what drug interactions there may be, and other kinds of things. Informed consent, you need to have a very specific informed consent process. It's a shared decision-making between you and the patient. They need to understand all the risks and benefits of their treatment, be realistic and clear about what you're offering to them, and the risks and benefits of alternative treatments or no treatments, what your role in the process is going to be, and what their role in the process is going to be. A treatment agreement, you should have a treatment agreement for anybody that's on pain medications longer than a week or two. Treatment agreements define what your goals are. What is your intent in this process? Again, patient and provider responsibilities, objectives that will be used to determine whether they're getting better or not. What is the exit strategy? How are you going to get this patient off these medications if it doesn't work? And that's a big thing for you to be able to do, is to tell them how you will get out of this once you're in it. Also, what your policy is on refills, calling at 5 o'clock on Friday night to get a refill of pain medications, what behavior will be monitored, and what will the consequences be. Patient monitoring, I know that you've got somebody that is going to be giving a complete presentation on monitoring, just that it should include urine drug testing, pill counts, and checking the prescription drug monitoring database. You could also consider, if you have a very high-risk patient, having the patient sign a release for you to be able to talk to family or friends to see if they're complying with the program. Then having the conversation, and I know that you guys have a presentation coming up on critical conversations, and I suspect that it deals with this, but you can say no to people too. If you feel that the risks outweigh the benefits of treatment, you need to say no. But in a nice way. Some of the complaints that I would get from people at the hospital system were that the patient treated them like a drug seeker or like a drug addict. That's not okay. And plus, those people can become very angry and come back to your office in a very violent state of mind. So it's not a good thing to be mean to people. Be professional, be kind and caring, even if you suspect that they're drug seeking. Have a policy on opiate prescribing and follow it, and make sure if you have other providers in your office that everybody's following the same policy. Do any of you have experience with situations where you don't prescribe drugs, but maybe somebody in your office gives them out rather freely, and the patients will seek to see that person, or they would call the emergency department to see if Dr. So-and-so was on, because they know that they can get opiates from that person. So make sure you're following the policy. If you need scripting, develop it. Offer alternatives. Don't prescribe based on emotion or pressure. Recommend waiting a week and going from there to see if the patient's any better. If you have a problem, review the case and refer to a specialist. These are some talking points that you can use. Tell me what you already know about the safety and effectiveness, problems with narcotics, so you can have the patient tell you what they know about narcotics and what they can do to them. We have two problems to address your pain, and the fact that opiates themselves can be unsafe, of limited effectiveness, and can do more harm than good. So these are some talking points that you can use. I'm happy to share these slides with you guys if you leave word with the organizing folks. I'm happy to share these slides with you so that you can have those suggestions. Always have an exit strategy. Again, you need to consider discontinuing opioid therapy if you're not getting meaningful improvement for the person. If the opioid doses are over 50 MMEs per day without evidence of benefit, if they have benzodiazepines and you're unable to taper them off, if the patient asks you to do it, if they want to be off these medications, and then red flag events. And red flags are asking for early prescription refills, their dog ate their prescription, unexpected medication showing up in their urine drug testing. If they tell you, oh yeah, I gave my pills to my mom because she had a headache, that's a red flag. If they're not safely storing their medications, if you're alerted by others that the patient is diverting or selling medications, patient altering, forging, or rewriting prescriptions, suffering an accidental or intentional overdose, non-compliant with the treatment plan, and they threaten you. That's a big red flag. Documentation of your care. This is something that I can't get over when I, again, review cases for a lawsuit, is that the person hasn't documented to anything that they've done. Number one, it's a reimbursement issue, right? Number two, it's a patient safety issue. And number three, it's a risk management issue, because if you don't have down there what you did to be sure to be able to show people, if you had to, that you provided appropriate care to this person. And this is something that I shouldn't really even have to tell you. Documentation for physicians, nurses, pharmacists, whoever, is so important to be able to show that you met the standard of care. Prescriptions, if possible, use electronic prescribing. If not, write out the prescription in numbers and letters. Don't sign incomplete or blank prescriptions. I've seen that in offices where I've surveyed the office, is they will have a prescription pad sitting out where the physician has written their name on it so that they can, someone else in the office can fill in the information. Make sure that you're educating the patient, consultations and referrals if needed, and everything else should be in the chart. And then auditing your practice. Are you regularly evaluating whether your opioid prescribing, dispensing, or administration patterns meet the standard of care? That's a big thing too. Sample auditing should include documentation. If your practice is deviating from your guideline, then you need to ask why and what you can do either to better document or to change your practices. Pharmacists need to do all the things that physicians do. They have their own, okay. Unfortunately, you guys, this just was too long, and I really apologize. We're done. I do have a copy of the slides. If you are interested in having any of those, or if you want to talk to me afterwards, I'm happy to answer any questions that you might have. So thank you very much.
Good morning. I have the pleasure to introduce our next speaker. My name is Carrie Haney. I'm a clinical pharmacy faculty with the Skaggs School of Pharmacy and the Family Medicine Residency of Western Montana. Our next speaker is John Miller, who is a friend and colleague of mine. And John wears many hats with his current job. He is the medical director of Partnership Health Center here in Missoula, and he's also the associate director for clinical operations at the Family Medicine Residency of Western Montana, which is also based out of Partnership. John and I started working at Partnership around the same time, and at that point, we did not have a lot of pain medication policies and clinics in Missoula. And John's been instrumental in starting our policy at Partnership Health Center. It's been a long process. He's done a lot of refinement to find a balance that works for patients, our providers, and our community. And he's been speaking nationally and locally on his work on this project.
Thank you very much. All right, hello everyone. Maybe I'll move this down a little bit. It seems like. All right, good to see so many folks here. I want to start by thanking Lynn for her talk. We didn't talk about how our two talks would go together, but I think she provided a lot of really good concrete information. And I'm going to tell a little bit about a clinic story and some personal parts about that story of how we got to what I think is a really good risk mitigation strategy or management strategy at Partnership Health Center. So again, thanks to Lynn for that, and I'm going to take her up on her offer to get slides because she has a lot of good concrete stuff that I think will help us improve as we continue to go along. So as you can maybe tell from that part that I learned from Lynn, I'm not really an expert in pain medicine. I don't claim to be. I'm a medical director. I was hired to be medical director at Partnership Health Center and to help start a residency program in family medicine. So, you know, one of the other things when I first got to Partnership is I inherited a panel of patients, and of the first 50 patients I saw, 17 of them were on chronic controlled substances that they assumed I would continue. That was way different than what I had experienced before, and I had to come to terms with that. Some of the issues with it that came up, one was a kind of an overemphasis on opiates as like really the only medicines that they were on, lack of openness of talking about alternatives or their history or their experiences, their functionality, some of the things that are now part of widespread guidelines. There was a resistance to that, even back in 2011 when I was taking over. Also on a clinic level, we had a lot of chaos around this, a lot of late prescription requests, a lot of blow-ups in the waiting room, a lot of anger, patient complaints. I felt like we needed to get things under control, especially starting a residency program where we were going to have new residents, you know, folks right out of medical school who weren't trained in this. We needed a system. And so what I had to do was go out and find a system. And there were some really good models out there. Riverstone Health was before us, so there's a community health center in Billings, and they had some folks who were doing some really good work on this, and a lot of what we did, we adopted from their work. We also got a lot of help locally from Montana Spine and Pain. They were really, Chris Caldwell in particular was helpful in helping me see kind of how things fit together. Also locally, Mark Mantell was helpful in the evolution of our policy as we've gone together. Also, I went to a national meeting of community health center medical directors, and we were talking about this issue, and a lot of the different clinics there just said, okay, we're done. We're not seeing patients with chronic pain. We're not prescribing opiates, you know, one or the other or both of those, and I just didn't feel like that was appropriate. I think it's not, I don't think that's a good response. Partly because, I have to say, as an educator, I don't think that would be a good way to teach, you know, 10 residents that we're graduating every year that the right way is to say we're just not going to prescribe. What we needed was a system that would help us decide. How do we decide as providers within our clinic how to prescribe? It sounds like maybe there's a little bit of reverberation going on. Is it clear back there? I'm okay. All right, good. I'm getting some feedback up here. It's a little bit uncomfortable. So anyway, we had to develop our guiding principles. What were the things? How are we going to do it? So I already told you about best practices. We went out to find out, okay, what are other people doing? Bouncing our ideas off. Some of those we rejected. Some of those we brought in, but we had to modify. I'm very evidence-based, or at least I like to think I am, so I wanted to go find the evidence. So what were some of the guidelines at that time? There actually were some pretty good guidelines at that time. Of course, the CDC guidelines weren't out yet, But I also, when I go to the guideline, I look to see, well, how did they decide on this or that? And so I'll get to that as part of this. The first thing we wanted to do, though, was to say we weren't going to prescribe controlled substances on our first visit. We needed that to be the message. Because patients were coming to us on a first visit, we knew nothing about them, like one of the cases there that was discussed, and they were expecting us to give them oxycodone. I'm sorry, I don't feel comfortable with that. That doesn't work for me. We needed to set an expectation that we would need to understand the history and the risk before we made a decision. The message to the patients was that's going to take 3 visits at least. But often we will fill on our first visit if the previous prescriber calls me, explains the history, explains the risk. We can assume a care in that situation. But the message to everyone else was we're not going to prescribe on the first visit. And the key was that we need to understand the full history and to complete a risk assessment. We need to try to maximize lower risk medication, non-controlled medications, also some of the other therapies that are more effective, like non-pharmacological treatments. Also, we're a primary care clinic. We're not a pain clinic, okay? So we needed to set what's our tolerance for risk as a clinic. And I felt as a medical director that it was appropriate that we focus on treating low-risk patients. And if we're getting a lot of red flags that people are medium and high risk, that we needed to go to referral support for managing those patients. We need to use the lowest effective dose. We have controlled substance contracts. And we do ongoing monitoring for everyone. So that's really what my talk is about right there. That's kind of a preview of coming attractions, what we're going to talk about. On the new patient evaluation, I think this top line is the most important thing, okay? You have to listen to the patient's story. You can't start with your evaluation, launch in with the reasons, what all's been tried, try to get proof of this or that, okay? You have to listen to the patient's story. If you take the time, uninterrupted, to have people tell you their story, they're going to be much more open to the changes that you're probably going to have to help them through as you go along. You'll be much more aligned in that. Have to ask about goals of treatment. What are your goals? What are you working toward here? History of past evaluations, treatments, ordering records. There's a lot to do on this first visit. We might start the risk assessment. One thing about us is if we start the risk assessment and we're seeing a lot of red flags, we are going to turn away from the question of whether we're going to prescribe opiates to how can we help this patient more broadly. Because we're not going to prescribe opiates at our clinic. So do they need a referral? How can we maybe focus on some other less risky medications? That sort of thing. We might also, on that first visit, plan for withdrawal if we are unwilling to prescribe and they're going to run out. We're just focusing on trying to help the patient. So I've got several slides here on the history, and they're kind of grouped. I'm just going to kind of go over them quickly because it started a little bit late. But the idea here is we need a very thorough history. We really need to understand where these people are coming from, what's happened to them, what do we know about it, what's been tried, and how can we help them. So on the cause, what did happen? Often they'll tell you part of it in the story, the open-ended questioning you start with. They'll tell you a lot, but you might have to ask some more questions to really understand what's the cause of the pain and what did it come from so that you can help them. Next, talking about non-pharmacological interventions, talking about what's been tried, what their experience was with some of these things. And I actually go through a pretty exhaustive list on this because I'm, in my mind, thinking about, okay, we can try physical therapy. They really haven't given that a good try. Maybe they quit early on it. Or osteopathic manipulation. We have a lot of resources for that at Partnership, and we feel fortunate. A lot of people haven't tried that, so that's a place to go with things. So as we're going through the non-pharmacological interventions, and also for the non-opiate medications, I'm looking for what are the other things I can offer this patient, especially if I'm not going to feel comfortable prescribing their medication. History of pain relievers. I'm going to spend a little bit more time on this because I really like to be concrete to understand how are they dealing with, okay, so they have this chronic problem. They'll often have acute flares. What's their pattern of taking medications that are not prescribed? or are not controlled, that maybe there's, again, an opportunity to help them with their pain without taking on the risk of opiate pain medications. And then specifically about opiate medications, how have they been used in the past? Okay, so often they come with a specific ask for a medication, like I took oxycodone before, I want that medication, or my previous prescriber prescribed me this. I like to get an idea of, okay, when did you start that medication? How long have you been taking it? How often do you take it? When was it last prescribed and by whom? Why are they not prescribing it anymore? I think often people come to a different clinic as an opportunity for a second chance because there were previous issues with their prescriber. We have kind of a low tolerance for that. We don't want to be the clinic of second chances, but we at the same time do want to remain open to the story and what the issues were. So we're not going to, it's a little bit of a red flag, but we want to work through that. But we do want to have that as a red flag if somebody's had their medication discontinued by another clinic. We're going to have to definitely get the information about what happened before we take that on. And then I would ask when the last controlled substance was taken, because we're going to get a urine drug screen if we're going down the path of consideration of opiate pain medications. Also trying to frame what I'm going to expect in that urine drug screen, I'm going to ask about other drugs that they might take. So is there any history of substance abuse problems that they've had, tobacco use history, alcohol intake, kind of signs that it's about the chemicals, it's about the medications for them. That's a little bit of a red flag that we need to look for as well. Again, these red flags don't dictate our decisions, but it's just a process of looking for them so that we can come to the right conclusions at the end. And then use of illegal drugs. I ask specifically if there's any drugs they take that are illegal, and they'll say maybe no. And then I'll ask specifically about marijuana because marijuana is illegal in Montana, and I'll ask about recreational and medical use of marijuana because that will play a factor later, as I'll talk about. So summing up the history, you can see it's a long time. It's a lot of discussion. It's a lot of information being gathered. I think you've got to do that before you jump to conclusions and coming to ideas about how you're going to judge it. So again, is the diagnosis or cause of pain well established? Is there evidence that those opiates helped them be more functional in the past? Can the patient maybe maintain the prescription from the previous prescriber while we're doing our decision making? If not, then I think we're going to probably have to support them through their withdrawal rather than us taking on the prescription. We're not going to take that pressure of their withdrawal as a reason to start prescribing before we're ready, based on understanding the history and the risks that we're taking on. Is the patient open to non-pharmacological or non-medication treatments? I think this is really important for decreasing the risk to the clinic. Is patients need to be on the lowest dose to try to mitigate their risk, both risk of abuse and risk of harm. And I think we need to try to work in these other areas to try to keep this down. And if a patient's not open to that, I think it's really hard to take on the risk of prescribing them opiates. So at the end of this first visit as we're talking, I'm asking myself, does this patient seem appropriate for being prescribed opiates? Does this seem like opiates could help this patient? Am I going to consider prescribing this medication? If I'm not, I'm going to start turning the discussion toward that and helping them understand the reasons for my concerns. And this is what I'm asking the other providers in my clinic to do. But if I do feel it could be appropriate, I'm going to keep going forward in the evaluation toward this. So the risk assessment is really important as kind of something that you're doing as part of the history taking, but then also there's specific tools that we want to use. So again, I'm not going to spend a lot of time on risk assessment. If I'm getting a lot of red flags early that somebody is high risk, I'm going to probably put some of that off and instead try to look at goals and how I can help that patient given the fact that they're high risk. Often referral will be part of that or others. Again, kind of discontinuing the risk assessment if you already know it's high risk. Don't keep going and putting them through a lot of different things. The history is really important, so looking at inconsistencies with the history, using tools, looking at the tools and the stories that they're telling and whether there's inconsistencies between those things. Reviewing the past records, again, looking for inconsistencies and what the story is. And then at the end of the first visit, I'm kind of, in my mind, I think this person's probably low risk for opiates, or this person's moderate risk, or this person's high risk, so I need to kind of go in a different direction. So risk assessment tools. This is a kind of a Moore wrote a review article that kind of brings it all together, brings together the evidence of what are the best tools that we have. And not surprisingly, it's a combination of the many tools we might use. So history alone, just with the history, you can get a lot of information that would predict aberrant behavior. The SOAP-R has really good data to support it. It's 24, I'll actually tell you more about that because it's the tool we use. The opiate risk tool has just 5 questions. It's not as, doesn't have as good data to support it. Standing alone as a risk assessment tool, the Dyer tool, which is a very cool tool and we still use it, but standing alone, it's not a very good risk assessment tool. I think it's more of a guide for decision making, and I'll tell you how we use that. So, but the information in this article points to using both the interview and the SOAP-R together as the most evidence-based, supported practice for risk assessment in the clinic. So that's what we did. So the SOAP-R is 24 items, a lot of great questions in there. It's good to review it as well as just score it. One of the questions, I think it's question number 4, is do you frequently have tension in the home or something like that? So if it's really tense in the clinic, you know, and in this encounter and they seem on edge and they're writing no, I'm like, okay, you're not being honest with answering this form. It makes it hard to do this risk assessment, and I would probably put off the discussion until later and try to come back to it later. So looking for inconsistency with the history exam, I think, is a key thing. It has pretty good sensitivity for detecting folks who are going to be to exhibit high-risk behaviors later on. Good positive predictive value. Nice thing here is the negative predictive value is pretty good. So if somebody scores below 18, they have a negative predictive value of 87%. So only 13% of those people will exhibit aberrant behaviors. So that's pretty good. And then for the folks who do score over 18 on this, they're 2.5 times more likely to exhibit these high-risk behaviors in their care. Urine drug screen is really a valuable tool. You have to ask the questions before you get the drug screen. You can't just get the drug screen. So asking specifically about marijuana, I think, is one of the key things that we do. Asking when they last took the medication and when was the last time before then, because if it's negative or at a really low level, you can get that information. Early on, we used kind of a point-of-care test that was not very effective. We got a lot of false positives and false negatives. I think we probably had an over-reliance on that test, so we learned a lot on that, and we did a lot better when we changed to chromatography, which is highly sensitive and specific. It can be expensive to patients, but it's becoming more affordable as we go along. And we went with a company that would give us a write-off of for folks who are less than 300% federal poverty level, which is almost all of our patients. So the cost to the patient was not significant. So I wish I could do this slide again, but I submitted those, and then I do have these brands on there. I don't have any financial disclosures here. I don't have stock in any of these companies that I'm aware of. But these are the two companies that I know a lot about, Millennium versus Ameritox. I've kind of looked at these two head to head. I'm now looking at Quest in competition with these two. We right now are with Millennium because they do write a lot of things off for our patients. Ameritox, I think the advantage of they have the patent on this graph right here. So this graph is kind of a mean bell curve for patients at that dose of opiates. Oh. Yeah, it's too far. But for folks on that dose of opiates, where does this person on that standard deviation? That's a really valuable tool that only Ameritox has. So there is some advantage to that. But that's not enough to sway us. We haven't moved to Ameritox in our clinic. One more thing about this. What was interesting about this is we had, like for example, a patient who says they are taking oxycodone, no other drugs, this kind of thing. On the point of care test, it's very hard to verify or refute that information. But with this chromatography, with the information that you get here, it is so specific that you can really say, yeah, you're taking oxycodone, but you're also taking hydrocodone. How does that fit into this picture? Or, also alcohol metabolites, some of these sorts of things that increase the risk of harm. Prescription Drug Registry is a great tool. It's part of our protocol to look at it if we're considering prescription. We also use it for acute pain patients because, like Lynn was talking about, folks will come in and say, I just sprained my ankle. It's good to look at that up before you go because you can see that they've been prescribed within the last month or so.
Do you need someone with a mic anymore?
No. Does it sound okay?
No, it's not. Someone just told me.
Is it okay? I'm being asked about the mic. Is that okay? It's okay. All right, I think we're okay. Let me check the time since I had my thoughts changed there. So this is out of a study, 2014. What are the aberrant behaviors, or what are we looking for in the prescription drug registry? So folks who use multiple pharmacies, early refills, multiple prescriptions from multiple providers, these are folks who are increased risk of opiate abuse, benzodiazepine abuse. These are folks who have personality disorders, more likely to have personality disorders as well. So this is important things to look at when you're looking at the prescription drug registry. And then in terms of dealing with other substances, the risks go up incredibly if you combine, sorry about the typo there, but if you combine psychoactive drugs, they increase risk. So that's in the CDC guidelines, not to combine opiates with benzodiazepines if at all possible. Requirements for sobriety, this is not evidence-based, but if someone has a history of substance abuse, we're not going to say that no way on that, but we do kind of have kind of a year's documented of sobriety before we would consider prescribing opiates, and then 1 month in patients who have used other drugs. So if, say, somebody came in and that initial UDS had methamphetamines or something, we wouldn't consider it until we had a number of UDSs that were negative for that. And so people say, well, marijuana, even marijuana? Well, the data's not super great on this, but I think there is increased risk of aberrant behavior as well as risk of harm associated with use of marijuana with opiates. And that's enough for us as a clinic to avoid combining marijuana and opiates. So then in the second visit, we're assessing the openness to the non-pharmacological, non-opiate pain medications. We have that preliminary risk assessment. We're taking the UDS results that came in 2 days after that first visit. We're kind of putting together that with the prescription drug registry. We're going through the records review. Okay, great, we've got the records. Let me sit down with you and talk through what's in these records. And then we use the Dyer tool. So the Dyer tool, I think, is really good for putting it all together, okay? This is out of a study of, I think it's 60 different cases, 6 different observers sat down with the data about these patients, really high level of inter-observer consistency using this tool, very high level of sensitivity for detecting noncompliance, efficacy, and disposition, whether these people would be continue on these medications based on their behavior and function. So the Dyer tool, using this information, here's just the data out of that article that looks at the compliance, the efficacy, and disposition. And you can see that there's ranges. If you look at the minimum and maximum here, you can see pretty broad ranges. But if you look at the means, they stack up pretty well to say that if you have a lower score, those folks are generally going to be less compliant. If you have higher score, you have support in prescribing these medications. Same thing for efficacy. Well, the cutoff here is maybe a little bit lower down. And then for disposition. So I think the Dyer tool is a really great place. Once you have all this information, what do I do with all this information? It's a thing where a provider can sit down, run through the Dyer tool, get a score, and say, yeah, this person's appropriate. I'm going to prescribe. So taking over the prescription, it's important to have a controlled substance contract, establish the purpose and endpoint, and then plan to get the person to the morphine equivalent dosing limit of 60 morphine equivalents per day. That's what we decided on as a clinic. We haven't looked at that since the CDC guidelines came out. At the time that we set this, it was like Washington State had a guideline of 120 morphine equivalents per day. We wanted to be a little bit lower risk, and we went to 60 morphine equivalents per day. And since then, the CDC guidelines have come out that give better support for our number. And then we want to, of course, do ongoing assessment. So we all know about morphine equivalent dosing. I didn't have a good table on here, so I kind of wrote it down the way I think about it. But the key thing is methadone is very messy. You have to sit down and calculate the morphine equivalent per day if you're changing from methadone to some other medication, because it's very confusing. Here's the data out of group health that helped us decide on 60 morphine equivalents per day. The CDC, basically, they cite this information to set their guideline of 50 morphine equivalents per day being a place where you should think twice. Am I really going to keep going up on the prescription here? And then 90 being a limit. So as you can see, the risk goes up as you increase the dose. Prescribing less than 20 is lower risk than 20 to 50, which is lower than 50 to 100, which is lower than greater than 100. We had a lot of patients over 100, and we've tapered a lot of those patients as we've gone. This is out of the North Carolina study that's just earlier this year that basically shows the risk going up with the average daily dose. Tapering to 60 morphine equivalents per day, it's important to give patients support as we do this. We might take on the prescription with an understanding that that's where we're going, and the patient needs to show a reasonable intent and consistency in moving in that direction, even though it's going to be challenging for them. The monitoring strategy that we set up, we start with monthly visits. We might throw in a pill count. She talked about pill counts earlier. I think pill counts are really problematic, especially for our population where they run out of phone minutes. Maybe they live in St. Regis. I don't know. They're problematic. You have to apply pill counts carefully. You need to let people know they're on notice and that they might get called for a pill count, which does take the surprise out of it. But that's how you're trying to increase just the fact that it's out there could increase compliance and help make the medication safe for themselves. So, and that's really where the data around pill counts are, is that it actually helps promote compliance rather than it being a useful tool to catch people. And so that's how you should use it if you're going to use it. So discontinuing opiates, I only have a couple minutes left, but I want to talk a little bit about this because this top point is the most important thing. And patients may not hear this, but if you're hearing this out in the community, they won't see me, they won't treat my chronic pain. That's just not true. That is not the message that we're giving. And if it is the message that we're giving, we're making mistakes, okay? The key thing is it's not the same as continuing care. They're not cut off. It's not that we're not going to treat them anymore. It's just that we're not going to prescribe this single medication. That's all it is. And that's really important to some patients, which to me is a sign that that medication is probably a problem that we need to talk about more broadly. So they need to, so we're going to offer a lot of support. We're going to help them through this transition. We're going to try to maximize non-opiate and non-pharmacological treatments, try to sell it to them as an opportunity for change. And we've had a lot of patients. I was telling you before that I had 17 out of those 50 first patients that I saw had controlled substances. You know, I worked with those patients when I went back and looked at those 17 patients when I was preparing for this talk at one point, and 8 of them are still in my care. 5 of them are on controlled substances, 3 are off of controlled substances together, and those 3, I think, feel like they're in good care. So I think we've retained a fair number of them, and we've helped them, I think, to a better place for pain and functioning around these problems. Pitfalls to avoid, I have just a couple of slides here left. This is really important to think about. When you put this kind of system into a clinic, everybody's going to act in different ways around this. One of the problems that we had was people will say, we can't treat your acute pain until the 3rd visit. that doesn't work, you know. Our system is for chronic pain, okay? So that's part of the history, is to understand. Now, patients will come in and they'll have a pain complaint that they'll try to sell as an acute problem, because it's an acute flare of a chronic problem. But there's ways to assess that. And if it is truly acute pain, we got to be sure to not undertreat acute pain. We need to avoid stereotypes. One of the things, monitoring for everyone. So this one patient really stands out to me. She was a 75-year-old, super nice woman, but she never took her oxycodone or whatever she was prescribed when I first took over her care. I'm pretty confident that she was helping to support a broad family network with those medications being sold. I mean, she was a sweetheart. I felt horrible, but you know, actually it was really easy not to prescribe because she never could produce that in her urine. The other issue is kind of same message from all patients, I mean from all providers, and Lynn talked about this as well. We all need to be on the same page. Patients will go from, okay, I didn't like what I got from Dr. Miller, let me go to somebody else in the clinic, let me go to somewhere else. So part of our policy is we have a pain committee. Nurses can refer cases to that to say, I think this prescriber's a little bit off. We are all checking each other. If we have kind of a case where we're not exactly sure, we might catch a colleague and talk about it, or we might send it to the committee to have a broader review of the case that I think is really helpful. The other thing is we don't want to stop treating the patient. We can't let the message be that we don't care about you, that we're not going to take care of this problem. We want to help with this problem. We want you to get better. We want you to be more functional. Okay, that's the message that we're wanting to give. Patients aren't always going to hear it, but I think that's really important. And then considering the risk of other medications, so the non-opiate medications for pain, there's increased abuse of gabapentin, Gabbies on the street, this kind of thing. So you have to be kind of controlled about that non-controlled substance. And then other controlled substances. So we apply this to our prescribing the same model. Risk history, understanding risk assessment, not making a decision before we're ready, trying to maximize benefit, minimize harm to all of the different controlled substances, whether it's benzodiazepines or stimulants or testosterone, anything. You know, we apply these same principles. So in summary, I would say do your own evaluation, do a full risk assessment, do your best to help the patient, use evidence-based tools, use them consistently for everyone so you're not stereotyping or picking people out. Try to set shared goals with the patients, do ongoing monitoring, and taper or discontinue medications if you have to, if you need to, all with a message of trying to help the patient in the long run. Oh, I do have one last slide, sorry. What are the effects on the clinic? So I said that of those 17 patients, I went back and I looked, okay, well, how about my last 50 visits? So my first 50 visits, I had 17 patients on controlled substances, and I had 4. I told you of the 17, 5 were still on controlled substances, but in the previous 50 visits, 4 of them, of the patients were on controlled substances. So I was seeing less patients with controlled substances, and that's definitely the case in our clinic and for our pharmacy as well. And so that was something that our administration had to support, is that it did affect our bottom line, where a lot of people with Medicaid, disability, went elsewhere. And for us, where we have a lot of people with self-pay, that actually affects us negatively financially. But as a clinic, we never looked back. We felt like this was the right way to go. We have had some shifts in our patient population, talked about this disabled, but we're also starting prenatal care, We have more kids coming into our clinic. We don't want the big blow-ups in the waiting room. It's not going to work for us. We're a family medicine clinic. So we need, it's had some really positive effects on the environment overall. Having boundaries gives us freedom in which to work, and we actually have less patient complaints, more patient understanding than we had. When Dr. Christensen's clinic closed, a lot of his patients came back, and a lot of them were really open to our strategies, and a lot of them have either been discontinued on their medications or come down to much more safe doses. And then, one of the key things is we've created a protected resident training environment. So, and that was kind of a key thing that we needed to set up for our clinic because we're a teaching health center, right? So thanks a lot for your attention. I'm not sure if we have time for questions or where we are time-wise. I'm looking for a sign. Looks like we might take a question or two. Somebody give me like a number of minutes until I have to be off the stage, if you can. What's that?
15 minutes, apparently. 15 minutes.
15 minutes for questions. Okay, let's go for it.
So quickly, I've heard 2 risk presentations. I would also mention that for the older population that is not as aware of what this epidemic looks like, that being prescribed medication appropriately for these conditions, they become targets. And so to be very aware where they put their medication, who knows about their medication, because I've seen it in Libby, I've seen it in the Flathead, that people have their doors kicked in, blah, blah, blah. So being very careful about, oh yes, I take hydrocodone, or who knows where it is.
Mm-hmm. Mm-hmm.
I like that last slide that you have about the effects on the clinic, and I'm wondering if that has an impact on your reimbursement possibilities, and how you would monitor those outcomes in a way that you could maximize your reimbursement and support for better pain management.
Well, that's a really great question, and I'm actually going to talk about that because that is very cool. I haven't been asked that question, and I like it a lot. One of the things is, in the short term, it definitely hurt us because our payer mix helps dictate the kind of money that we collect. And at the time that we instituted this, we were greater than 50% of our patients were less than 100% federal poverty level. And the other thing was that maybe we had 15% Medicaid, and our Medicaid went down to 10%, which has a huge effect. Some Medicaid paying $150 per visit versus self-pay being $15 per visit. There's a huge financial impact. But in the long run, like we're a level 3 patient-centered medical home, we're doing a lot of pay for performance. Not yet, but we're moving away from fee-for-service. We're moving away from the number of visits for which payers, this old way of thinking about it, to who's taking the best care of their patients. And I think that ultimately we're going to be able to make good arguments about this, partly because we have really good data around depression screening and intervention. If folks are positive for depression screening for all of our population, not just for people with chronic pain, integrated behavioral health is really key for that. So my hope is that this is one of the steps, one of the early steps that we had to do to help our clinic get better toward a better place in quality. And I hope that in the future we get paid for that rather than being on the treadmill, seeing patients one after the next.
Excellent presentation, Dr. Miller. Just a comment on the assessment. Sometimes our patients are reticent to share their psychiatric treatment history and their substance use disorder treatment histories. Mainly their fear is if I have an acute pain issue or if I need surgery, I won't receive adequate care. Mm-hmm. So sometimes it takes a little work to get at that history. The other thing that I see in my population also is on the front end, we do very good comprehensive assessments. And sometimes, and then with the continuing care and issues arise, we don't necessarily go back to that initial assessment and define, what were risk factors at that time. So they can kind of get lost in the past. So in a way to keep those risk areas coming forward. I know Partnership does a really good job of that with your ongoing problem lists and so on. So, and the other part of this is that I think the shift is, what we did with the HIV epidemic was we implemented universal screening, incredible public health intervention. In a sense, I think we have to do the same thing here, implement universal screening around risk factors for opioid misuse.
I guess I would comment on the first of those. I appreciate all of the comments. But that issue of patients don't always want to be forthcoming at the beginning because they're afraid we're going to judge them. That's true. That is definitely true. And I think the evolution that we've had, I think initially was if, okay, you didn't tell me about your substance abuse disorder when we talked. It's in your record. Why didn't you tell me? There's no trust here. You know, this kind of thing. And I think we've evolved to a better place now where we just have that be like the next part of the discussion, and just understanding that we can't make a decision about prescribing these high-risk medications, high risk for harm, high risk for abuse, to patients until we fully understand the history and the risks. So if patients aren't forthcoming, it's just going to put off the decision. That's all. It's not a big deal. And maybe it feel like a big deal for the patients because this is taking forever. You said it was only 3 visits. Well, I mean, the first 2 visits were maybe wasted because I didn't hear about your substance abuse disorder that you used to have. We found out about that in the records. I want to work through that to really understand what would be the risk of me prescribing. So that would be my comment about that. So while this may feel very rigid sometimes for patients, I think we have a lot of opportunities for exceptions, working through that with the committee, where ultimately I think we've come to a place where we can better treat patients with this kind of structured approach. Yeah.
What do you do about marijuana in the UDS, or just, somebody who says, yeah, I occasionally smoke marijuana?
I think generally we talk a little bit about the risks of combining psychoactive medications. Mostly there it's about risk of harm. There's a little bit of data around risk of abuse as well. But risk of harm is a better place to focus the discussion of risk because it feels like less attacking. People get less defensive if you're talking about risk of harm. I guess I'm talking about patient education there, exploring how patients individually would want to assess their own risk, and are they willing to make changes themselves? How important is it to them to continue using marijuana? How important is it to them to get this prescription for opiates? I'm not going to prescribe to somebody who's marijuana. I've never made that exception. Definitely not with stimulants. That would make no sense to prescribe stimulants to somebody with marijuana. That would make no sense. Maybe the risk of harm data isn't strong enough that you can make an argument for an exception with marijuana and pain medications, but you'd have to stay at a pretty low dose. I wouldn't totally object to that, but as a standard in our clinic, we don't prescribe opiates or any controlled substances to folks who use marijuana. That could change. We don't have that same sort of restriction for alcohol. Alcohol is legal, marijuana is not legal. So I think that's kind of a key issue. And if you come with the argument, well, I have marijuana for medical reasons. Well, medically, it's important for us to mitigate our risk, and we aren't willing to accept the risk of prescribing opiates for somebody who's taking marijuana for those reasons. So, that's kind of a evidence-based argument, that I'm making. I would try to make it in a more caring way with the patient to help them understand the risks that I'm concerned about and help them make choices that ultimately decrease their risk, mostly of harm. That's what they're worried about, but I'm also concerned about risk of abuse. Yeah, Cam. Oh, we have another one. Okay, here we go.
So for your new patients that are complex and trying to absorb assessment of chronic pain management, what's a typical appointment timeline? That first appointment, like how long is that appointment, knowing that you're going to handle a lot of other medical issues, and pain management is probably a small piece of that. And then what's the turnaround to bring those patients back for that second to third visit? And are you using any other providers in your clinic to help accomplish that?
Great questions. That's awesome. So we have 40 minutes for new patient appointments. I was going to make a joke, but I'm not going to. We use 40-minute new patient appointments. Our typical appointments are 20 minutes, so it really feels like a hamster treadmill sort of thing. The key thing is you have to address what's really important for the patient. And often that's what the patient wants to talk about. So you might only talk about their pain the first couple times you see them because you have to address that issue. But if they're hospitalized for a heart attack, you maybe have to focus on that and come to pain later. So you have to pick your priorities of where you're going to go. We do have really good support in our clinic. We have integrated behavioral health, like I was talking about, so there's good support for counseling, coaching. Our behavioral health managers do some of that. We also have Psych APRN, John Honsky, who is really valuable in helping us with some of the psychiatric medication questions that come up. So if people are on psych meds and also wanting opiates, boy, you need help. That's a very high-risk situation that I think the CDC really well delineated, really clearly, great evidence in that document to show why combining psychoactive medications are problematic. So you're going to have to get the full team in. It's going to take a long time. Patients are going to have to be patient with that. I think increasingly, well, let me say, when we first said no prescription until the third visit, patients were like, you got to treat my pain now, what about this? But we don't get that anymore. That's an old way of thinking. So I think patients are accepting of people working through the risk, understanding the history, and coming to an informed prescribing decision.
How are you handling alcohol monitoring with your urine drug testing?
Yeah, great question. That's one of the things I did not expect when, yeah, I'm learning as I'm going. Like I told you, I've just learned from Lynn's talk. But so when we first got this Millennium result back, and Millennium's just a brand, I know, but UDS chromatography, they had this alcohol metabolites, and I was like, well, what's this? And so I had to figure out what that was. And so I had a patient who scored 25,000 or something so I had to figure out what does that mean or something like that, and that's like 10 drinks or something like that. I didn't feel comfortable with him drinking 10 drinks in a night and then taking hydrocodone even at the small dose he was on. I thought the risk of harm was very high. He was actually in his 80s. So he's had to decrease his alcohol in order to maintain his medication. He's wanted to do that, so I used it as a tool kind of to monitor his alcohol intake and help him with what I think was probably an alcohol abuse problem. It's kind of gone away. We only had to talk about it once or twice, so maybe it wasn't an alcohol abuse problem. Maybe he just went to a party or something like that. But so we do use that information in that kind of way. Usually not punitive, but more supportive to decrease risk to the patient.
Have you established a cutoff level that prompts that conversation?
No. Do you recommend one?
Well, unfortunately, the answer is that there is no good data to demonstrate that within a population a certain level is indicative of a certain number of drinks. However, we use 100,000 on the ETG as a level that prompts a conversation, because in conversations with other people, representatives from labs as well as other physicians, that level has been established as being fairly heavy use the night before or use the day of the testing. So that's kind of where we start. My second question was, and I may have missed it earlier or forgotten, how are you handling benzos with opioids?
Yeah, so sorry I jumped the gun on my 25,000. When 100,000 is the cutoff, I feel a little apologetic now thinking about that. That's
well,
a lot of
like
alcohol, though, isn't it? Yeah, I guess if it's not predictive of actually how many you drink. But he actually admitted to drinking a lot, so he was pretty forthcoming. So, and I think it helped him. But I'll think about that 100%. May talk to you more about that because 100,000. So, and then the second question, I'm blanking on. Sorry.
Benzos and
opioids.
Benzos.
So when we first did this, we didn't have the CDC guideline, which I think is really clear about avoiding prescription of opiate with benzodiazepines. What I thought What we did when we did it was, we're a low-risk clinic. This is going to make it high risk. We need support for this. We need some specialty support to say our benzo is the best medication, because in most cases they're not the best medication. And then specialty support, our opiates the best medication, because again, in general, they're not the best medication. So for patients to have 2 not best medications on their medication list, the risks of harm are so great, not to mention the risk of abuse. So patients were usually pretty open to that, especially, again, if we talked about risk of harm, they're open to, oh, there's this risk. And we definitely saw that, where before we developed this, we had patients who got into trouble using those 2 medications together. So it was very intuitive for people. People were very accepting of it on a clinical level. And now it's in the guidelines, so it's kind of a moot point at this point.
We have time for just one more short question, and then I'm afraid we'll need to be done. Thanks.
Okay.
Dr. Miller, what are your policy recommendations for wean initiation following inconsistent UDTs? Because the debate for our pain committee is when a patient comes up positive for stimulant and negative or positive for an opioid, are the risks outweighing the benefits? Or if they're negative for their opioid, do we need to initiate a wean out of courtesy, out of ethical, legal, moral obligation?
That is such a great question. That is so awesome. And I don't know. I mean, it's so much easier. It's so much easier if it's not in their system, if it's a negative, if it's inappropriately negative, it's easy. You're not taking the medicine, we're going to discontinue prescribing. That's really easy. But I'm actually currently struggling with this case of a patient who is on too much opiates already. I've tried to get her down, and she's been resistant to that. And now she has methamphetamines in her system, and she's not being forthcoming about why they're in her system. So it's like, where am I going to go? I feel like I am probably justified in just discontinuing your medications with what I've prescribed. I think the risk of harm, the risk of abuse is probably the big risk here, and that's for me to control the community risk. But that's just opinion, really. I don't know. I think some people would argue that I need to help wean her off of it, but I think I will probably discontinue prescribing that single medication and try to offer support for her otherwise, try to get her the substance abuse counseling probably that she needs while she does that, and prescribe other medications to help her through her symptoms of withdrawal.
I'll just add something for Dr. Miller that I happen to be his partner, and I'm very happy to be working with him. But one thing that John has forgot to mention or forgot to embellish that our community recently did to help with the ethical questions is we put in place a medication safety committee. So if any of our providers have any issues with what's happening with the medications, it's not a single person making a decision. It goes through a committee of other providers who are actually looking at this and helping to give advice to our other providers of what we can do. So we're trying to address that ethical piece remember this is kind of an ethical conference of how we best do things. Sometimes it's hard to do in smaller organizations, but you can still bounce things off partners and talk to other people about what they're doing. And when you get these tough cases, it's hard to make that singular decision. But that's one of the things that John hasn't promoted that he should be very proud of. So.
Yeah, but it sounds like you were referring to your committee. You're using that same kind of structure, so I think that's great. It's just how do you make the decision? And I think that the risk of harm to the community is probably greater for somebody who is abusing these medications than the risk of harm. The risk of harm to the patient would be for discontinuing these opiates. So that's where I would come down on this. I think other people might come down in a different place, and that's perfectly reasonable. I think they're both within the community standard. It wouldn't be within the standard to just continue the medication and not address the problems on the UDS, though. So, all right. Well, thanks to everybody. Great questions. I enjoyed this very much. Thank you.